I know we have families coming in, and we want to be able to get started, and it's just an honor to be able to present this next presenter to you all. My name is Terry Klein, and I would like to introduce Dr. Joseph Muenzer. He is a Bryson Distinguished Professor in Pediatrics and Genetics and a professor at the Department of Genetics at the University of North Carolina at Chapel Hill, where he's practiced since 1993. He has a PhD in biochemistry since 1979 at Case Western Reserve University in Cleveland, Ohio. He is the director of the Joseph Muenzer MPS Research and Treatment Center at the University of North Carolina at Chapel Hill, an academic-based philanthropic program created to improve the lives of mucopolysaccharidosis in individuals and their families. I've been privileged to know him both as a parent and as a professional for many years, and I have to tell you, it's just such an honor to have him here on the stage, because when I travel with him around the world, families look at Dr. Muenzer as a rock star. So welcome, Dr. Muenzer.
Thank you. So thank you, everybody, for being here. It's certainly my challenge to talk to an audience that has new families and some families who I've known for 20 years. And so what I want to do, and actually for some individuals who I've known for 40 plus years, I'll just shout out to Joan so she can sort of, it's at least 40 years I've known Joan, probably about 45 actually, as I met you at the NIH. I just want to point out that I am this director of the Muenzer MPS Center, an academic-based program, and we're happy to see families who want sort of second opinions. For some families who can't afford, depending on what their insurance is, there's support for that. So clearly, some of you already contacted the people on the hallway in terms of Kristen and Leanne, but please do that more. I want to actually dedicate this lecture to a dear friend of mine who passed away this spring, Dr. David Whiteman. David was really an important advocate for the MPS community. Some of you probably don't know that, but he really was just a unique figure. He interacted, he was very active in terms of pharmaceutical, former geneticist who really thrived. So we miss him dearly. Have disclosures. I consult and serve on advisory boards for biotech companies, and I'm also a principal investigator for a number of clinical trials. Have a lot I want to cover in my time, and hopefully that time will allow, but I want to just talk about sort of the initial serendipity that led to MPS therapy, talk about the pathophysiology. I want to spend a little more time talking about glycosamine glycans and how we measure them and some of the challenges. And I realize some of the material you'll see for some of you may be new and overwhelming, but for others, hopefully it'll be just give you another increased understanding of some of the complexities we deal with. Talk about CSF, or cerebral spinal fluid heparan sulfate, as a biomarker, and how it's been used, the FDA accelerated approval pathway. And then just really the excitement of newborn screening for MPS 1 and 2, and really the need for doing it for others, the current treatment options and the limitations. And then I want to really end with about 6 or 7 slides just showing you how much is happening today in the MPS space in terms of different clinical trials, and I'll give some closing remarks. So actually my mentor was Liz Neufeld, who discovered the basic defect in the MPS, and that was she realized the MPS fibroblast accumulated could not break down glycosamine glycans, because the other theory at the time was the MPS cells made too much, but she really showed that they accumulated it. And this is actually some of the data that here, the squares are what happens if you take skin cells or fibroblasts from individuals with MPS and expose them to radioactive sulfate. Because the glycosamine glycans are heavily sulfated, they can be labeled, but what you see is that labeling occurs, but then it levels off, just showing you that the constant turnover, where if you take MPS 1 and 2 fibroblasts, they just keep accumulating that label, they never get rid of it. And that was the basis of showing that it's really inability to break down or degrade. But then in the lab, by chance, she was planning to do this, but by chance, the technician mistakenly mixed an MPS 1 and 2 cells together, and she was really so bright that she realized this circle, the dark circles, that they both corrected each other. And that was that unique exposure, that unique experience that she had that really told us that one cell will leak out fibroblasts from another, but more importantly, cells will take up. In this case, she called them correction factors early on with the missing enzyme, and that allows this correction to occur. And it's really the basis for all the stuff we do now in terms of getting treatment for our MPS individuals. A lot of you have seen this slide. I'll just repeat it for some of the newcomers. These are lysosomal enzyme disorders. A lysosome is a function of the cell that's involved in recycling or breaking down components. There's 12 known disorders, 8 different clinical types. As an aggregate, they're about 1 in 25,000, but each individual MPS is in 1 in a million, 1 in 100,000 to 1 in a million. Unfortunately, these are progressive disorders with multi-system involvement, a lot of different involvement, and then because of a lot of factors, these are highly variable diseases in terms of for each type. And I just showed this slide showing individuals with MPS, and you can pick out, and I'll just point out there's an adult with MPS 2, and there's an infant with MPS 1, a Sanfilippo, and a Morchio. Just an example, just showing you the variability, and this is, I'll talk a little more about this in a second. So what's the so-called pathophysiology? What does that mean to me? So the question is, how does this enzyme defect, which results in GAG accumulation, result in disease? And so that's the term in medicine we use as pathophysiology. So one of the major issues is the amount of residual activity appears to be one of the main drivers of clinical severity. That is how much residual enzyme you have. Really, if you have no residual enzyme, you have the severest form. But for example, in MPS 1, almost all individuals have less than 1% residual activity measured in the diagnostic assay. But that really drives severity. In MPS 1, historically, they're Hurler, Shea, and Shea. Individual has no enzyme whatsoever, always has Hurler syndrome, the severest form. But if you have half to 1% residual activity, you could actually have spared neurologically, but still have physical disease. So it's just important, this spectrum, this neurologically, that individual with Shea will never develop profound cognitive impairment, where the individual with Hurler syndrome untreated will develop profound cognitive impairment. One of the reasons for some of this variability we see in the MPS is that the major types of glycemic glycans that accumulate are not equally distributed throughout the body, and therefore when they accumulate, they're not equally distributed. And that's an important concept. Heparan sulfate is found throughout the body, but it's more prominent in the central nervous system, where dermatan sulfate, somatically, and for example, keratin sulfate is primarily stored in the bones. Yes, you can see it other places, but so this is a generalization. And this unique storage of these GAGs result in this wide range of clinical disease you saw previously. But more importantly, whenever you have the GAG storage occur, there's a lot of so-called secondary events. Again, the GAG storage, what occurs initially due to the enzyme defect. And that's given for all the disorders. But then what happens afterwards is really the challenge. And this slide is just a cartoon of that. I really like showing you if you have an abnormal gene mutation and a deficiency of the enzyme, and then you have GAG storage. But I won't go through this, and I could actually spend the rest of my time just talking about this slide and what we know and don't know about the pathophysiology. But there's all sorts of other events. And more importantly, when some of these events get going, it's hard to turn off. And so it's just a good example. And then this is just, I won't again talk about these, but I'll just mention them. These are 4 common mechanisms of how these stored GAGs cause individuals to have all the different clinical symptoms in terms of impaired autophagy, where the body can't recycle, for example, defective mitochondria. We have increased inflammation or neural inflammation, which clearly contributes to disease severity, particularly probably in the Sanfilippos. Cells can't talk to each other, therefore they have a problem communicating. And then we also see a lot of secondary storage. That is, the gags are the primary storage, but other things store, and they themselves can cause additional damage. So it's a very complex process in terms of pathophysiology. But enough for pathophysiology, but I want to go now back to the basic defect in the MPS. And so each MPS disorder, by and large, results in a deficiency of an enzyme that doesn't allow gags to be broken down. And here I show on the right side dermatan sulfate, one of these stored materials, and the MPS 1 enzyme, ironidase. This enzyme should normally cleave off this sugar right here, this ironic acid. And I'll come back to the non-reducing end in a little bit later in the talk. But if you can't clip that off, then none of the other enzymes downstream work. In the same way, if you look up a bit right here, there's a sulfate, a 2-O-length sulfate on ironic acid. If you can't clip that off, which is a defect in MPS 2, then ironidase does not work. And these molecules only work from this so-called non-reducing end, and that's because of the nature of the way these sugars are linked together. And these sugars are asymmetrical, and so you can only work when you have this sugar that does not have a glycosidic linkage. Okay, we have lots of different types of glycosimic glycans in the body. Like a lot of other things in the body, they need to be turned over or broken down. But the glycosimic glycans are typically connected to a protein backbone, or a so-called proteoglycan molecule. So the GAGs plus the protein are called proteoglycans, and these are very common in the extracellular space. But you can see example different GAGs connected to this. And they're always connected to one end. So again, these GAGs are asymmetric in terms of their structure, and that's important when you talk about this non-reducing end, because there's only one end of the GAG molecule that's non-reducing. As I already alluded to, the glycosimic glycans are not evenly distributed, and because of the nature of the disorders, that's what we see in MPS 1, 2, and 7. Those enzyme defects all store both heparin and dermatan sulfate, and they all have physical disease, and a significant component of them have neurologic or develop severe cognitive impairment, where in contrast, Sanfilippo children only store heparin sulfate in the brain. They primarily have a neurologic disease, can have some physical involvement, but nothing like we see in the MPS 1 or 2 or 7s. And then you contrast that to Meritolamine or MPS 6, where they only store dermatan sulfate. And for those of you who are aware, that disorder does not have any profound cognitive impairment. They don't develop cognitive impairment, but they can have severe physical disease similar to what we see in MPS 1, 2, and 7. And then Morquio syndrome is very different in terms of what's stored. It's keratin sulfate, and that's primarily a bone disease with other secondary effects, and the bone disease drives a lot of the pathophysiology in that disorder. So it's just an example of what's stored causes the defect. So what about now? Let's talk some structure and why this is important. Glycosimic glycans or GAGs are long, linear, that is, they're connected one to the other polysaccharides, that is, sugar molecules that consist of repeating disaccharides. And that term disaccharide may not be common to a lot of people, but it means two sugars together. So a disaccharide is two sugars linked together. And these disaccharide units are unique to each GAG. A very busy schematic slide, but if you look at heparin sulfate on the top and dermatan sulfate here, what you see is you have this ironic acid that's diamond with a brown that occurs in both heparin and dermatan. But what you have then next in the disaccharide is a different type of sugar. In heparin sulfate is N-acetylglucosamine, and in dermatan sulfate is N-acetylgalactosamine. So these are important so that we can literally, I'll show you later, you can cut these into disaccharides, and those disaccharides are unique for that disorder. So how do we quantify? And this is one of the big improvements in science that occurred that really allows a lot of things to happen that we couldn't do 20 years ago. Historically in the US, as you heard if you heard Chet Whitley talk yesterday, GAGs were measured using colorimetric assay using the dye dimethylene blue that basically measures total GAGs. It doesn't distinguish from dermatin or heparin or from keratin. And that was great, and I would guess that most individuals in this room who have been diagnosed with MPS 5 years or later all had that total GAG assay as a way to confirm they had MPS. But in the early 20s, because of technological and scientific advances, we can now quantify the specific GAG that is dermatin compared to heparin or chondroitin sulfate because of utilizing a technique called liquid chromatography tandem mass spectrometry. And you'll see that abbreviated LC-MS. More importantly, that technology itself has improved. The mass spectrometers in the last 20 to 25 years have dramatically improved their sensitivity, and so we can do so much more with them today than they could do in the past. And this, again, is a powerful analytical tool. That means you can quantify with it that combines the physical separation capability of the liquid chromatography. We can separate out things, and then we can use the mass spectrometers basically to quantify and identify. So it's really a unique system that allows tremendous capability in terms of quantification. In contrast to total GAG that were typically measured by the dimethylene blue assay, today there's actually 4 ways to quantify specific glycans or specific disorders, so-called non-reducing ends. And those 2 methods there, Sensipro and endogenous. I'll come back to that in a second, but I first want to say that if you look at that dermatin sulfate I showed you before, again, these schematics here are the chain going to the right. They go a long ways to the right. There's many, many molecules, but the non-reducing end, this so-called opposite, this other end, for MPS I, that non-reducing end is always iuronic acid because that's what the enzyme can't cleave off, as I alluded to earlier. For example, right here, you can't cleave off this iuronic acid. For MPS II, it's really, as I alluded to earlier, it's iuronate 2-sulfatate. It's 2-sulfated iuronic acid. That's the non-reducing end. And for MPS VII, down here, it's really a glucuronic acid. So each disorder has its unique non-reducing ends. And there's now methodologies available that Maria Fuller and other people have developed, which allows you to look at a GAG analysis using the tandem mass spectrometry and determining what type of MPS disorder that is, where you, in theory, don't have to do enzyme. Enzyme still should be done to confirm that, but you can actually get away, in theory, from enzyme. So again, these 2 non-reducing assays, the Sensipro was initially developed, but then this endogenous non-reducing end that Maria Fuller, basically taking the GAG molecule and using the new sensitive technologies, can identify small fragments and again identifies do you have an elevated MPS or not, because if you don't have significant non-reducing ends, you don't have an MPS. But those just measure non-reducing ends, even though you'll hear more of that. There's also, you can take the either chemical or enzymatic cleavage and chop up the disaccharides. And as I said earlier, these disaccharides are unique to each GAG molecule, and you can actually quantify, for example, heparin sulfate as an accumulation of 4 different disaccharides added together. And the technology is sensitive enough, and you can quantify that to really allow a very robust determination with very good sensitivity. So again, it's important to realize that all GAG assays are not the same. Depending on how they're measured, they could be very different interpretations. So I can't compare right now one lab to another. They may do it differently. This just shows you a slide of the cerebral spinal fluid heparin sulfate and MPS II. This is data published by Denali from their phase 1-2 study. And these are the baseline heparin sulfates that occur in the MPS II population. And what they have on this slide is this sort of darker blue line. Below that is, in theory, normal. So we all have heparin sulfate in our spinal fluid. It's just that the MPS II patients have dramatically more, and that's really a toxin to the brain. I just want to point out, you might be able to see it very well, in this phase 1-2 trial for Denali, there were 3 individuals who were considered attenuated. These are these triangles here, and they also have elevated. And so it's not always clear why we see elevated heparin sulfate in the attenuated. We also see it typically higher, but not always, in the neuropathic or severe. But this assay would not be possible 15 or 20 years ago. We couldn't do this because of technological advances, and that scientific advances has really dramatically improved what we can do today and result. As a lot of you appreciate, this ability to quantify heparin sulfate in cerebral spinal fluid of the MPS II individual allowed for the recent approval of Avlea using the accelerated approval pathway. Without this, Avlea would not be approved, and there would still be trying to work on if you had to do clinical endpoints, which are much more challenging to do and take much longer and can easily fail because of the variability in the population. So what is the accelerated approval pathway? You've heard a little bit about this already, and I'm just going to talk about it. The FDA instituted this accelerated approval pathway to allow earlier approval of drugs that treat serious conditions and fill an unmet medical need based on a surrogate endpoint. So what's a surrogate endpoint? Actually, it could be a laboratory measurement, a radiographic image, it could be a physical sign, or other measures that are thought to predict clinical benefit, but not itself a measure of clinical benefit. Just lowering heparin sulfate, that doesn't say that patient's going to get better. And I can say if you already have significant neurological injury with MPS II, we can lower their heparin sulfate in their spinal fluid, but their brain has already been impaired. So it's important to realize that it's not a measure of clinical benefit, it's a predictor of clinical benefit, because again, we know if you can lower it early on before you have damage, you can do much better. Again, the concept of a surrogate endpoint should considerably shorten the time required to receiving FDA approval, and that's currently the story with Avlea. As with any new drug application, safety has to be demonstrated prior to approval. That's one of the things you can't just have decreased biomarker, you have to show safety. Drug companies are still required to conduct studies to confirm the anticipated clinical benefit, but they can be spread over much longer, 5 to 7 years, for example, where you have a chance to easily see the difference between a treated patient and the historical controls. If for accelerated approval, as Avlea has, if the confirmatory trial shows the drug provided a clinical benefit, then the FDA can grant traditional approval for the drug like any others. But if it doesn't show approval, they in theory have the ability to withdraw that drug. And unfortunately, historically, the FDA has not taken advantage of that. And there's a lot of people who have been against accelerated approval because it's like a gift to the drug company because a negative study hasn't been withdrawn from the market. And so it's important that there's been controversy for some people, accelerated approval. But for the MPS community, it's absolutely important because it allows us much earlier access to therapy for our individuals. Why should we use accelerated? Why should heparin sulfate? Here, I'll just give you some of my rationale. The enzymes in MPS are all lysosomal enzymes, and they only work within the lysosome. They don't work in the circulation, they don't work in the cytoplasm, they only work if they get into the lysosome. Heparin sulfate is the primary material that's stored in the brain of neuropathic individuals with MPS, and it's really what the toxic issue is. We know from extensive animal studies that the CSF heparin sulfate level correlates with brain tissue heparin sulfate levels in animals. So if you lower animal brain tissue, you lower CSF heparin sulfate and vice versa. More importantly, CSF is not a puddle but a river. It turns over, so again, it reflects sort of what's happening in the brain. The only way for CSF heparan sulfate to be decreased is that the enzyme enters brain cells, goes to the lysosome, and reduces the heparan sulfate stored in those lysosomes in those cells, and then those cells no longer will leak heparan sulfate that results in the elevated CSF. Again, it's very, from my perspective, lowering CSF heparan sulfate is reasonably likely, not a guarantee, but it's reasonably likely to predict clinical benefit based on a lot of studies and a lot of data. Change gears again. Newborn screening has been a major advance. Currently, newborn screening for something called PKU that occurred over 50 years ago is one of the really successes of medical genetics historically. MPS patients are incredibly rare. I estimate there's less than 2,500 MPS individuals in all the US. That's the rarity. MPS 1, 2, and 3A, the three most common ones, probably have a prevalence of less than 500 in the US. The typical pediatrician in the US may see 1 or 2 MPS patients in a lifetime in their practice, and they most likely have missed patients. Each MPS disorder is very heterogeneous or very variable, with variable times of disease onset and rates of disease progression. But in general, MPS individuals appear normal at birth. The one exception is for MPS 7. A lot of those present with so-called non-immune hydrops. That is a unique disease that we see typically for other reasons, but can occur in this population. And that's the common presentation. But most MPS individuals, you cannot recognize. And I examined another of MPS 1 and 2 individuals who had prenatal diagnosis, so I knew they had it, and I could not be convinced on physical exam that they had MPS 1 or 2. Although most appear normal at birth, the storage starts in utero and is demonstrated as early as the first semester. Children with the severe form or neuropathic MPS are typically normal at birth, can develop normally for 1 to 2 years before developmental levels regress at various times and rates. So they basically develop normally, slow down, plateau, and regress. The clinical diagnosed MPS patient with developmental delays and cognitive impairment, what we typically see prior to newborn screening, already has significant impaired neuronal function that is most likely irreversible. Most families experience a diagnostic odyssey. People in the families in the room, how many of you have taken more than 1 or 2 years before you were convinced your child had an MPS disorder? If you could just raise your hand. How many did not have a diagnostic odyssey? Because there was, very few, because again, of prenatal diagnosis and newborn screening now. But that historically is a significant issue. Intravenous ERT to treat this somatic disease is FDA approved for 5 disorders, but only prevents or slows disease progression. It does not correct disease. So the point is that you can't sort of pick them up at 5 years and then treat them and they're all normal. That just doesn't happen. And we now have robust enzymatic testing methods available to perform newborn screening for all the MPSs. Unfortunately, we're only doing it for MPS 1 and 2 currently. A lot of you appreciate MPS 1 was added to the U.S. Uniform Screening Panel, the so-called RUS, over 10 years ago. I estimate today that greater than 95% of the U.S. infants born are currently screened for MPS 1, 95%. MPS 2 was added to this RUS, this Recommended Uniform Screening Panel, in 2022. And we've seen a much faster uptake because, again, screening for MPS 1 for 2 is very similar to MPS 1. And I estimate there's probably 50% of the U.S. population currently screened for MPS 2. I should note that West Virginia has been screening for MPS 4A, and I don't know if they've even detected anybody, but they have been screening for that. And there's a pilot study in New York screening for a variety of MPS disorders. It's important to note that the initial test and measurement for newborn screening is measuring the deficient enzyme activity, but that second-tier testing, additional testing, is needed to decrease the so-called false positive rate due to pseudodeficiencies. For MPS 1, if you just measure enzyme, for every abnormal enzyme less than 10%, 5% of those individuals will have MPS. So there's a very high so-called false positive rate. And this is due to really that we see changes in the DNA that result in decreased activity of the enzyme, but that decreased activity of the enzyme is not enough to cause clinical disease. So important so-called pseudodeficiency, even though it's not a great term, it's there. You can screen. Second-tier testing can either be DNA sequencing or measurement of the so-called endogenous non-reducing N, and that's really an important concept that's really helped us on the initial bright blood spot, or you could do both. It turns out that the endogenous non-reducing N is much better at reducing the false positive rate from pseudodeficiency variants than it is for DNA. So I strongly recommend that any state screening use the non-reducing N as part of the second tier to really help minimize that false positive rate. What are the benefits of newborn screening? It can be performed measuring activity on the bright blood spot. The high false positive rate can be reduced using second-tier testing. It eliminates the diagnostic odyssey, which is significant, and improves treatment outcome because we now can identify early and prevent problems from occurring instead of trying to correct problems. But there are limitations like anything else. We're now detecting infants with normal total GAGs. So historically that would be, but they have mild elevations of heparin sulfate that we do not see in the clinically diagnosed patients. So it's important to realize that just because you have a little GAG elevation, that may not be MPS. We have the inability to predict the phenotype, that is, what severity for the asymptomatic individual with newborn screening positive. And we clearly now are detecting mild or attenuated MPS individuals that historically would not present clinically too much later in life. But it's hard to, we can't sort of pick one or the other. We have to do newborn screening. I have shown this slide many times, but for the people new to the audience, I'll show it again. The correction of enzymatic correction is possible at the cellular level in the MPS fibroblasts due to the following observations. As I alluded to earlier, cultured cells release small amounts of lysosomal enzymes that my mentor Liz Neufeld termed correction factors, which then she recognized to be the deficient enzymes in those disorders. There's a very efficient mechanism to get an enzyme from outside a cell to inside, so-called mannose-6-phosphoreceptor-mediated uptake. And again, you only need a small amount of correction to restore that normal GAG metabolism in a cell. I'm just going to skip over this for time. The two treatment options are hematopoietic stem cell transplantation and intravenous IV enzyme replacement. Where's Paul at? I'm going to leave HSCT to Paul. You'll hear a lot more about that in the next. And just briefly sort of say, the current FDA-approved IV enzyme replacement therapy for MPS is in 2026. Aldurazyme for MPS 1. For MPS 2, we now have two, Elaprase and Avlea. We have nothing, unfortunately, for Sanfilippo A, B, C, or D. We have treatment for MPS 4A and Vimizim. We have nothing for 4B. We have Nagozyme for 6 and Mepsevii for 7. But what are the limitations of this therapy? Requires weekly infusions from everything except for Mepsevii, which is every other week. Incredibly expensive. But some of the somatic features, the physical features, are not always responsive to either IV enzyme or to transplantation. The lining of the joints, the so-called synovium, the trachea in the MPS 2 patients, the bone disease in MPSs. Corneal clouding is really not impacted, and carpal tunnel by and large is not impacted by our current treatments. Treatment options for most MPS patients with central nervous system disease are limited, except one you'll hear about severe MPS 1 in terms of transplantation. In Japan, ICV ERT and brain penetrant IV ERT is available, but nowhere else in Asia. And again, this recent approval of Avlea in the US for Hunter syndrome. Unfortunately, there's no approved treatment or currently available for all individuals with Sanfilippo syndrome and the CNS disease in MPS 7. What are some of the treatment lessons we learned in the last 20 years? Progressive storage of GAG results in irreversible damage for a lot of things, and that's based on our current understanding of how much enzyme. If we gave a lot more enzyme, we may see some differences, but right now and hopefully this statement will change in the next few years. Treatment is always better at preventing disease than correcting. That's always going to be the case. And again, clinical outcomes are improved when started before the onset of clinical disease. That's always going to be the case. It's much easier to prevent problems than trying to correct. We do see some clinical benefit improvement occurs after ERT, but this is typically limited. And I show historically the first MPS patient, MPS 1 patient, or MPS patient 2 at MPS 1, ever to receive IV ERT that Emil Kakas was involved with. Here, pre-treatment, had a lot of the typical features of Hurler-Scheie syndrome. Post-treatment, you see some improvement, but he never got any better than this. He got some improved joint range of motion, his liver and spleen went down, but he still had cataracts, he still had corneal clouding, and he had lots of other issues that did not change. Partial reduction of stored GAGs can be beneficial, as we've seen, but is really not adequate for maximum benefit. And that's one of the challenges with our current treatments, either transplantation or IV ERT. We're not giving as much enzyme as we really should be giving. The weekly IV infusions at the ERT doses used with native enzymes, that is the enzymes were prior to Avlea, which is a fusion protein, have little impact on avascular tissues such as corneal, carpal tunnel, and synovial bones. It just doesn't get in there, one, because they're relatively avascular, but two, it's not enough enzyme. Increased enzyme dose with improved uptake and or small molecules to reduce GAG production may be needed to correct or prevent storage in the avascular tissues and structures. And Matthew yesterday alluded to this small molecule, and that may be really what we need for some of these too. So looking to the future, we'll really focus on the MPS brain disease, especially in MPS 2 and MPS 3A and 3B, and gene therapy that will replace the weekly ERT using the following approaches. Directly putting the enzyme into the spinal fluid, so-called intrathecal, use of intravenous enzymes that are brain penetrant, like Avlea, and then gene therapy, either IV, intrathecal, or ex vivo in terms of hematopoietic stem cell transplant that Paul may or may not talk about. I can't predict. My hope is that the rare forms of Sanfilippo, such as 3C and D, will receive clinical research attention in the near future. So here are those different approaches. What I want to really spend the last of my time just summarizing what's currently out there in terms of treatment. So active or planned, there's some MPS intrathecal ERT trials. I was involved for years in the Takeda IT trial. Many of those individuals benefited, as you heard yesterday from Jeff Weeder talking and his son, but that trial never got approved. There's ongoing intrathecal for MPS 3A by GC Biopharma. Spruce Bioscience will pick up the 3B that got terminated because of lack of funding for the company. And then hopefully Phoenix Next will come up with a treatment for 3D, and they're planning to do that. So those are the planned or active trials for intrathecal enzyme. What about the active or planned IV brain penetrant enzyme clinical trials? JCR has something for MPS 1. Denali has a product they have not put to the clinic, but could at some point. You heard, in terms of JCR has a product, JR141, that's actively being studied. Denali recently got approved. Both JCR Pharmaceutical and Denali have treatments for MPS 3A, and Denali has a IV brain penetrant product for 3B. So lots happening there, but then gene therapy. Gene therapy is basically a means to put into cells the missing enzyme and let the body produce the missing enzyme instead of having to produce in a $100 million factory, the recombinant enzyme. So there's two forms of gene therapy. IV gene therapy, where we give the so-called vector, that is the delivery device to get this DNA into the cells. Either can give it intravenously or put into the spinal fluid, so-called intrathecally again, or studies in the past, if you heard from Chet Willey, talk about intraparenchymal, that is direct injection into the brain, or injected into the spinal fluid within the ventricles, or injected into the base of the brain. All means to get, and the intercisternal is what REGENXBIO is doing for MPS II. There's also ex vivo gene therapy, where cells are collected in the body in the laboratory, infected with the lentivirus carrying the gene of interest. Those cells are corrected and given back, and so called ex vivo gene therapy. That really looks promising also. So I just, again, want a list of some of these trials. For MPS I, there's an ongoing phase 2-3 trial for MPS I using ex vivo gene therapy for Orchard. 2 patients, to my knowledge, Immunosoft has treated using B cells, where they've infected B cells with the MPS I gene, and now these B cells are factories to make enzyme. There's been an AAV9 intrathecal trial for REGENXBIO that's shown really good promising results, but unfortunately got put on clinical hold because of a brain tumor recognized. We hope in Chapel Hill, and UNC Chapel Hill, to do intercorneal injections of AAV9 to clear the corneal clotting in the next, in the future. And there's a proposal to do IV modified T cells like the B cell, correct those T cells, give them back, and let them produce a missing enzyme. All for MPS I. For MPS II, REGENXBIO has an active therapy for MPS II doing intrathecal injection, basal cistern. A Spanish company has done intrathecal AAV9, and then at Manchester, University of Manchester in UK, they've done ex vivo gene therapy with lentivirus for 5 patients, and those results are too early to tell you what's happening. For MPS IIIA, the Spanish group has dosed some intrathecal AAV9, Sanfilippo patients. Again, University of Manchester has done an ex vivo lentivirus for MPS IIIA, and 4 of those 5 patients have dramatically done better, just showing you when you put a lot of enzyme in, they do better. And then hopefully we'll see approval in the US for intravenous AAV9, initially the Aviona program that Allogenix took over a few years ago, and hopefully that'll be approved. So the first MPS IIIA gene therapy approval in the US. For 3B, this company Aviona did initial trials for AAV9, now taken over by Sangro Biologic, and they hope to follow what Ultragenyx is doing in terms of getting approval for that drug. You'll hear tomorrow an intravenous novel AAV capsid. One of the challenges of gene therapy is really the ability of the AAV9 to get into the brain by IV, and you'll hear some very exciting news about some of the newer vectors that may actually come a long way in improving these, what gene therapy can really do compared to the current AAV9, which is beneficial but not ideal. And Phoenix Next is proposing an intrathecal AAV9 gene therapy for Sanfilippo C. Nemours Institute, Nemours Children's Hospital in Delaware, through the NIH Bespoke Gene Therapy Program, is going to do intravenous AAV8, and then the patients in Europe with MPS VI who have received AAV8 intravenous gene therapy with really not a lot of great results, but they're going to hopefully increase the dose and use immune suppression, and hopefully we'll see some more results in the near future there. So just a whirlwind of what's happening. Preclinical animal studies in the last few decades have primarily focused on 2 delivery systems, lentiviral vectors and adeno-associated. There's been at least 20 human gene therapy trials have been completed in progress. To date, there's no approved gene therapy for MPS disorders. I hope that changes the next time I talk to a group like this. It is hoped that AAV9 gene therapy for MPS IIIA and possibly intrathecal for AAV9 gene therapy for MPS II will be approved this year or shortly thereafter. I'm amazed and pleased with the number of biotech companies in the MPS space. 30 years ago, the answer was 0. Today, they're 30 plus. Scientific advancements in the last 20 years will result in more MPS disorders and many more MPS individuals to be successfully treated in the near future. I'm looking forward to the next 10 years and seeing a generation of MPS individuals who were treated early with improved therapeutics, who will not be recognized based on their physical features or their abnormal development. Basically, today I can recognize most MPS patients that are untreated, but hopefully in the future that will not be possible. Thank you for your attention.